Hello, and welcome to That Implementation Science Podcast, the show that aims to reduce the innovation to implementation gap to 16 and a half years. I'm your host, Mike Pullman, and on today's show, co-host Kevin King and I will interview Leopoldo Cabassa and Dani Adams about implementation science's role in psychedelic assisted therapy. We'll talk about the evidence for psychedelic assisted therapy, its implementation barriers and facilitators, the role of implementation science in moving psychedelic assisted therapy from the clinic to the field, and we'll get them started on some excellent rants about implementation science. Now, just take some deep, calming breaths, close your eyes, and lean into the experience. All right, everyone, welcome to That Implementation Science Podcast. Today we are here with Leopoldo Cabassa, who is a professor and co-director of the Center for Mental Health Services Research at the Brown School of Social Work at Washington University in St. Louis. His research focuses on physical and mental health inequities in historically marginalized racial and ethnic populations with serious mental illness. We're also here with Dani Adams. She is an assistant professor in the College of Health Sciences at the University of Missouri, a social work researcher, an advocate, and an educator who is focused on improving the implementation of mental health services in under-resourced communities. And we're also here with my good friend, Kevin King.
Hey, Mike. Good to be here.
All right, it's so good to have you two here. How are you all doing today?
Doing good. Thank you for having us.
Yeah, I'm doing great. Thank you for having us here and ready for some questions. Yeah.
Yeah, well, it's so great to see you. I first met Dani maybe 2.5 years ago at the Society for Implementation Research Conference and was super impressed with her work. I think that was one of the best presentations I saw at that conference. And I think wanted to get her on the podcast way back then, but it never really happened. And so then I went to the next circ 2 years later, because that's how slow I am with things, and then bumped into both of you doing this presentation about psychedelic assisted therapy and implementation science and how those two things are related. And psychedelic assisted therapy is something that I'm very interested in. It's a topic that's been emerging. And so we're really, really excited to have you on today to talk about some of this work. But I think before we talk about how implementation science may play a role in psychedelic assisted therapy, I think maybe some of our listeners, this is an intervention that is kind of new to them, and they might need a little bit of a better understanding of the clinical intervention itself, and maybe some of the evidence behind it as well. So maybe if one of you could just give us kind of a overview of kind of what are the sort of substances that we're talking about at the heart of psychedelic assisted therapy, and how do they express themselves?
Yeah, I can take that. Psychedelic assisted therapy is kind of a multi-component intervention that includes both a medicine in addition to psychotherapy. So some of the substances that have the most research on them right now are MDMA, and that has really been studied looking at post-traumatic stress disorder or PTSD, as well as psilocybin, kind of colloquially known as magic mushrooms. And that has been kind of looking at major depression disorder, treatment-resistant depression, anxiety, and a variety of substance use disorders. So what's unique about psychedelic assisted therapy is that it kind of has a model that it follows. So first looking at preparation, then dosing, and then integration. So typically there's 2 to 3 preparation sessions, and this is really where you are preparing the client for what they'll experience during their dosing sessions. So it's really kind of focusing on what we call the set and setting in this area. So kind of getting the participants' mindset ready for this alteration that they are bound to experience through the psychedelic dosing session, and also introducing them to the setting. So typically the setting is a little bit different than normal psychotherapy room because there is a space for the participant to lay down during the dosing session. So that's preparation. And then during the dosing session, the participant ingests the psychedelic, and then depending on the substance, generally takes between 6 to 8 hours. for that dosing session. And that's where the participant may experience alterations in consciousness, in their perception, potentially even visual changes can happen. And then finally is integration sessions. So those typically happen sometimes the next day, sometimes a few days afterwards. And that's where the therapist really works with the participant to make sense of the psychedelic experience and really kind of help the participant integrate those experiences into their lives. So that's kind of like a broad overview of psychedelic assisted therapy. Leo, is there anything you wanted to add?
No, I think that, well, yes, I think there are two things. First of all, these medicines are not new. These medicines have been used for millennia in different indigenous communities through the Americas, particularly for community purposes, religious ceremonies, and other components. And it's part of sort of their cosmology and community understanding of their worldview as well. And then there's been sort of this resurgence of this research starting in the late 1990s and forward. And so the evidence, Mike, that you were talking about, most of the evidence that we have right now has been some randomized control efficacy trials in very constrained environments with very narrow diagnostic categories. And it's sort of going through the process right now, FDA approval. But that unique element of this is a real integration of both a medicine that alters consciousness and some type of therapeutic support that's happening through this component. So it's really this multi-component, as Dani has indicated, to address sort of the mental health needs of the participants.
Yeah, so it sounds like there's a kind of a nice structure that's been developed. I'm really kind of curious about the therapist's role. And Dani, you touched on this obviously to talking about the preparation and dosage and integration. Specifically during the dosage period, though, what sort of role does the therapist play while sitting in the room with the patient?
Yeah, so typically there are two therapists in the room during the dosing session. That's kind of changing a bit based on some of the industry-sponsored clinical trials that we're seeing happening, where there's only one therapist. But best practice is really two therapists in the room because the patient is kind of going through this like increased state of vulnerability in that time period. And so having two people in the room is really useful. And so during that 6 to 8 hours of the dosing session, the therapist, and it really kind of depends on the model. But for example, the model that Leo and I were trained in through MAPS, the Multidisciplinary Association for Psychedelic Sciences, they trained us to be very non-directive during that dosing session. And so what that means is you are really encouraging the client to go inwards and to really kind of have their inner experience and to not actually be engaging with you a ton. During the preparation sessions, you'll talk to them about what they want to address. So potentially if you're working on PTSD, you might touch on the trauma that they experienced. And then during the dosing session, if they don't talk about the trauma at all, if it's not coming up for them, you may prompt them. But you also might not, especially if it's the first dosing session. You might wait until the second or the third dosing session once they've had more experience with that substance. Another thing that's a bit unique to psychedelic assisted therapy is during that dosing session, there can also be the use of touch. And so this also needs to be discussed during the preparation sessions, and the participant has to consent to any use of touch in advance of the dosing session. But hand-holding can be something that occurs during the dosing session because participants often want some sort of physical connection to another person. So that is also unique, but typically it's pretty non-directive. And oftentimes we also ask the participant to put on even a blindfold to encourage that inner process to happen. Music is another really important part of the dosing session. So typically there's a curated playlist that lasts 8 hours that kind of helps the participant kind of move through the different stages of their trip. And so they may have headphones, or it could be happening during, like through a speaker during the dosing session as well.
I think one way that we think about it is that the therapists are holding space and providing safety and comfort during this altered state of consciousness that the participant may be experiencing. So it's really holding that space, being attuned to what's happening, providing reassurance if the person needs it. And it's very non-directed. Sometimes there's very little interaction that it's happening, meaning verbal interaction and talk. It's more sort of holding space, checking in. In some of the protocols, there's also space for taking the blood pressure, checking on the person, and making sure that everything it's happening as it's supposed to happen, and holding that space for the participant during the time. So it's also it may seem that there's nothing happening, but it's very intense because the facilitators need to be very attuned to what's happening non-verbally with the particular participant, and being comfortable with silence, for example, for hours on end.
Definitely.
So it seems like there's nothing going on, but there's a lot going on in terms of what the facilitators are, and holding that space and working as a team. It's also a newer thing in this type of therapeutic modalities.
So I'm wondering what's the state of the evidence for the effectiveness of these treatments?
Depending on the medicines, or MDMA, which is not a classic psychedelic, it's more an empathogen. There's been, the trials have gone all the way to phase 3 trials. So there's been multiple trials, and they've shown promising effectiveness for PTSD and treatment-resistant PTSD to the point compared to a placebo. And that evidence seems to be particularly strong, although it did not get FDA approval last fall for multiple issues that we can get into. But it showed, compared to what we would expect from a psychotherapy or existing medicines for PTSD, that this was actually a little bit better. There's also trials for psilocybin that also showing impact in depression and treatment-resistant depression as well. And that is currently in a phase 3 trial, and it's expected to be go through the FDA sort of approval process in the next year or so as well. So the evidence is mounting, is promising, but again, these are small efficacy trials, and then some of them have reached the phase 3, which we're talking 100 or something people that have participated. There's some newer trials emerging right now with LSD on general anxiety disorder that are going through phase 2 to phase 3 trials, and then some initial trials on DMT, which is another classic psychedelic that's being done. So all this to say is that it's sort of efficacy at this point, and the process is to show sort of safety, tolerability, and then initial impact in very narrow diagnostic windows, meaning treatment-resistant depression, treatment-resistant PTSD, general anxiety, or that type of thing. So it's sort of this efficacy sort of components.
Yeah, one question that comes to me, and I was followed a little bit the sort of MDMA challenges, and I saw there was, if I remember correctly, on Science Twitter, maybe it was Blue Sky already at that time, there was sort of a lot of back and forth about, like, should we really be pushing for this? And I saw groups saying that we're actually way ahead of the evidence, and other people saying, actually, no, it's really strong. And I guess I'm wondering, where do you feel like, you're sort of saying, I think I'm hearing you say we're in the initial phase of evidence. We're showing these things are tolerable, these things are safe. How would you compare where we are with psychedelic assisted therapy to other interventions that, at the point of implementation? Let me put it a different way. So, when folks started saying, hey, we have exposure therapy, let's put it out there in the world, right? We know it's effective, let's get it out there. What I'm hearing is, I guess I'm wondering how you think about this balance of what we know about efficacy versus pushing and thinking about implementation. Where do you sort of see that? And I ask that because I think the way I've often thought is we first establish efficacy and then we go to implement once we know it's efficacious. I know that we're thinking differently in the world now, right? We're thinking about hybrid, implementation trials, trying to establish efficacy and effectiveness and, implementation characteristics at the same time. How do you think about that balance, about how well we think these therapies might work, and actually how broadly we want to put them out there in the world?
I can start with that, Dani, and then we can do it. So I think, and actually, Dani, what was the title? We recently published 2 papers on this particular topic, Kevin, and the one from Dani, I'm forgetting of our title, speed at the innovation at the speed of safety or something like that.
Yes.
Yeah. So it's sort of like there's a signal here. The efficacy trials are showing that these treatments are safe if done under a controlled sort of environment and the right supervision and training, and they show some initial impact on major sort of outcomes for PTSD and depression. However, there are multiple unanswered questions that, as we think about implementation, it seems that we have to be very careful here. So, for example, a simple one is comorbidities. This has been studied in very narrow, as I mentioned, diagnostic windows or diagnostic categories that are not really reflective of real world routine practice setting where it's really rare for someone to just have PTSD and nothing else, right? A PTSD is comorbid with substance use disorder, depression, and other physical health conditions. So that's one of the things that we are trying to figure out right now. What are the right sort of comorbidities and safety profile if this goes out into routine practice settings? That's one sort of major component. The other piece here is that you have this FDA approval, like what we do with psychotherapies and medicine, show the efficacy, show the impact, and then implement it. But in the United States and in other parts of the world right now, there's other places that have looked at the evidence and said, we're going to implement it, regardless of whether it's been approved. A case example is Oregon, which is now, I think, in its second year of implementing a facilitator approach for psilocybin. And then Colorado started this year a whole new program. So this is a very different world of that compared to other psychotherapies and mental health treatments. So to the work that we have been doing is really thinking through what are those unanswered questions that could help as we think of implementation. Safety, one component. The other major thing is workforce development. Who's going to deliver these services given the existing behavioral healthcare system in this country and the shortage of providers that are needed? What type of training, supervision to maintain the quality, not only access, but the quality of care of this complex intervention? So I think it's that balancing that we still have some unanswered questions, but I think that's where implementation science comes right in, that we don't have to completely wait until everything gets approved to begin to think about these things, to begin to answer some of these questions and begin to blend sort of the efficacy trials with implementation things in mind. That's what we're trying to do in some of our work, to think about these different things, because this wave has come. This is coming already. It's out there. There's also people using this outside of regulatory environments. So there's also the cat is out of the box in a sense. So there's other important questions that we need to bring, and implementation science, I think, can help in addressing some of these issues. But that's just
right. In a way, you can answer a lot of these questions along the way with well-designed, exactly right. And you can answer them in a rigorous way.
Right. And that's where, when we started this is both new to Dani and I. This is not our areas of expertise in the sense of having many years doing this work. And when we got trained about a year and a half ago, it became very clear to say, wow, implementation science can really help this. There was a lot of unanswered questions that the people who are moving this in the efficacy sort of world were blind to it or not considering it. And that's where we think, okay, here's where implementation science can begin to think about some of these issues, to think ahead of this process. And that's what got us what got me very interested in blending these areas of work.
Yeah. No, just to expand on that, a lot of the research that's been done in the area right now is sponsored by industry and pharma, right? With the overall incentive to make a profit, right? To take a substance like psilocybin and then ultimately, turn it into their own compound that they then market, right? So they don't have as much of an incentive to think with an implementation hat on. And so I agree with Leo that that's where it's been really fun to come into this space and think, okay, pharma is thinking through these kind of implications around efficacy, safety, tolerability, but we have to be thinking about how do we get this treatment into the hands of those who need it most, right? And into the workforce of people who are actually serving those folks, right? So for example, social workers. How are we training social workers in this model so that they don't have to go and do a $10,000 certification program? So that's something we're really thinking critically about is how can we integrate training for psychedelic assisted therapy in social work programs that already exist. So that's been really exciting to work with our colleague, Dr. Heidi Allen at Columbia, and think about, building in training and workforce support, so that ultimately when these treatments are approved by the FDA, we have a workforce that's ready because demand is going to be high and we really want to be there and ready to kind of respond to that.
Man, $10,000 to take one of these trainings seems like I need to branch out and brush up and start offering some psychedelic assisted therapy trainings, huh? Can have a whole second
Seriously.
income.
It's serious. And it's not only the fee for the training. For example, in Oregon, you also have a licensing fee once you get the training. So the cost is pretty prohibitive. And, in order if you're going to do that, Kevin, in order to make actually any profit, that cost needs to be then transferred to your clients and trickle down to a client to it. So accessibility is becoming an issue. And we're not seeing, we're seeing some of those discussions in pharma and industry trial, but it's not where their head is at. And that to us is very essential to the work that we do, having worked in the behavioral healthcare system and concerning that this could replicate inequities or exacerbate inequities that we already have in the system. So I think those are some of the things how we do. And, places like Oregon have been thinking about equity issues. Don't get me wrong. They have thought about these questions, but the structure of the system that they have created is really creating some issues around cost in particular, given sort of how it's been developed. Yeah.
You guys talk about pharma as if they're drug dealers. So the one question, one thing I've noticed, so I'm in Seattle and obviously I get a very different view of things than much of the rest of the world, but I have a couple of underground therapists just in my neighborhood alone that I know. And it's a pretty common thing. And other friends who've used these services or used the legal services, right now ketamine, for instance, since it's, correct me if I'm wrong, but I believe since it's not a Schedule I drug, it can be used kind of off-label. And so there's this kind of ketamine treatment facilities that have popped up everywhere. But what I find really fascinating is that the legal service, the ketamine service, as it's been described to me, is almost like a dentist's office without as much sort of the pre-work or the integration work after. People go in and they get the treatment and then they kind of leave. And I imagine there's a wide array of experiences, but that's the experience I've heard of. Versus the underground kind of illegal treatment that's going on seems to be a lot more kind of in line with or have high fidelity to the process that Dani was describing earlier. Is this something that I'm just seeing, or is this something that you kind of hear about? Is this reflective of differences between what legal and underground services look like right now? Or if you could just talk about that a little bit.
So for ketamine, for sure, has been this industry. It's a medicine that has been approved for treatment-resistant depression and depression, particularly people that have high suicidality ideation and a high risk for suicide. But it is sort of just the ketamine, just have this experience, have this infusion, and then go home. And hopefully it's being integrated. Hopefully you have a therapist or the person that prescribe you the ketamine that's able to sort of process that. But the original trials of ketamine were just in an infusion and that's it. And ketamine is a different medicine than psychedelics. I mean, it has psychedelic properties, but it's an anesthesia, analgesic. So it's a very different sort of brain mechanism that's happening for it. But there's this industry that has come up. We've seen it. You're seeing it in Washington State. We're seeing it in Missouri. All these different places where you go in there, you get an infusion, then you go home and you feel better. But it's still very costly. Not health insurance may cover some, but there's high deductibles. So that there's sort of this lack of like the integration of psychotherapy, and that's sort of a discussion in the field right now. Like, do you need the psychotherapy? You don't? Is it just a brain chemistry change that's happening, and that's all we need to target? And the psychotherapy is not necessary. We don't believe so. I think there's a lot that can be integrated with psychotherapeutic on it, but it is an issue. The other interesting thing with ketamine is that it is not a Schedule 1, but there's potential for abuse and serious physiological impact if you abuse ketamine to the point of overdoses. So there's a lot of other issues involved there that we have to pay attention to. And actually we can learn from that implementation or the errors of implementations in ketamine. Yeah.
So you really
Yeah.
go ahead, Dani.
Oh, okay. I was just going to say ketamine is fascinating because there's really three forms of ketamine that practitioners are working with right now. So that's the IV that Leo mentioned, and that is typically not paired with psychotherapy. But many therapists are actually working with sublingual ketamine, S-ketamine. So that's the nasal spray. And so those forms of ketamine are more likely to be paired with psychotherapy. We don't have as strong of data, though, on what that looks like, pairing ketamine assisted therapy. And so that's actually a research area that I'm really excited about, is thinking about how can we build out this literature? What does it look like to pair ketamine with therapy? Because we know with ketamine that it is pretty effective, especially for depression, but typically those symptom alleviation, it doesn't last super long. It's typically like 3 to 6 months. So if you compare it with psychotherapy, especially S-ketamine, which just got approval for insurance coverage beyond just treatment-resistant depression. You can now use it for major depression. So I think there's better insurance coverage for S-ketamine versus IV too. And so that, I think, really deserves a lot more research. And then, Mike, you also mentioned kind of this underground world too, where there's practitioners who are using, whether it be psilocybin or MDMA, DMT, paired with psychotherapy with their clients. And we don't have great data on this in terms of, how frequently it's happening, what sort of support those folks are getting, if any, what outcomes look like. So I also think that this is a really interesting research area to better understand, because like Leo said with ketamine, we can get an early sense of what are some of the implementation challenges that folks are encountering.
I was just reflecting that, it sounds like what you're focusing on is bringing a bit of a sense of rigor to what may feel like a little bit of the wild, wild west right now, and I suppose from one perspective, it makes sense. There are medications, people say they're effective. And when you have a medication, you can just one perspective is you just take it, you just get the infusion, you do the trip, and that's the thing that works. And it sounds like what you're focusing on is, well, how do we build, test, and understand the structures that might, that surround this to be safer, hopefully more effective, and also thinking from the implementation standpoint of how do we make this more accessible and more standardized, so that people, when they say I'm getting a psychedelic assisted therapy, it sort of means the same thing, rather than what it sounds like now is it could mean a whole really variety of experiences around.
That's right. And actually, that's a great point, Kevin, because, for example, right now we're examining different therapeutic manuals that are public to examine what are the common factors that are across to make sure that we understand what the standardization of it could be. And it could help sort of in thinking about implementation. Then these are the standard components that then we can train and supervise on, and then examine the fidelity of that work to address sort of the quality of care components. So I think that's an important component. One thing that I worry about the underground also is, remember, these are Schedule 1 substances. These are illegal substances. So what people are using in the underground, people have to be very careful about what substances are actually being consumed. And some of them may be good, some of them may be adulterated with other substances. So the quality, the actual molecules, the actual dosage is unclear, and that's some safety component that we have to pay attention to.
Yeah, and that standardization piece really matters because right now there is not a gold standard, even in regards to how many preparation sessions should there be, how many integration sessions, should psychotherapy even be provided, right? The new phase 3 trials for LSD, they intentionally do not have a psychotherapy component. Even the person who's in the room during the dosing session, they are not a licensed therapist. They are meant to be a support person who's there for safety, but that's kind of it. And so there's really kind of open questions in this field around what standardization should look like. Even if psychotherapy is paired with the model, the type of psychotherapy is hotly debated. Should it be CBT? Should it be acceptance and commitment therapy? What about IFS? Right? So there's lots of open questions about standardization. And I think that that is a huge area where implementation science can contribute.
There's a lot of stigma behind this as well, and I think for maybe for some good reason. What you're talking about right now, Danny, is, I mean, we know there's a lot of questions still to be answered. The trials have been relatively small, but sometimes huge effect sizes, almost unbelievable effect sizes. And we know, even if you studies don't need to be done to prove to someone that these are incredibly powerful substances that can have profound effects on people's minds. I was listening to a podcast the other day. It was talking about how they feel like many psychedelics reopen sort of, what is it, the critical periods, and allow
Yes.
for some more flexibility in thinking, and so people can, and so these are interesting theories about why these things may or may not be effective. I'm curious, as we talked earlier, Kevin was asking questions around whether it's time, whether we have enough safety data, whether we have enough efficacy data for implementation science to be paired with psychedelic assisted therapy at this point. And it sounds like we're feeling like, from you all, that it's already out there. And so we need to be thinking about ways that this can be done again in ways that are safe and most effective. I'm curious, what are some of the really major barriers to getting this done? We've discussed some of them already a little bit. We haven't really talked about stigma too much, but you talked about the training requirements. You talked about, obviously, there's legal implications. What are some other sort of major barriers right now to implementation?
So Mike, one of them, and I'll start with this, Danny. So one of them, so part of some of the studies that implementation science can do actually are addressing this. We're doing a study where we're interviewing early adopters of psychotherapy, of psychedelic assisted therapy, people in Oregon or Colorado, other people who participate in trials, to think about, these are people who have done it, who have seen it, who are beginning to implement in Colorado and Oregon. So from those, we're beginning to identify some of those barriers. And one of them that comes to mind is that this is a real paradigm shift of how we deliver behavioral health care in our nation. This is not about what is it? This is about sort of very one or two sessions that you're doing for addressing, say, really complex mental health issues. It's a medicine that you might take one or two times. It's about sort of that interaction and that quality of the care, versus our system is about volume, about fee for services, about many sessions over time, taking a medicine every day, and compliance with that medicine. So this requires a whole other sort of set of understanding, and it's sort of a professional cultural shift of how you address it. It's also, these medicines are addressing something that we sometimes don't talk about a lot in the behavioral health case. This gets into spirituality. This gets into sort of altered state of consciousness and past trauma, future things. So there's sort of this, we have to think about that paradigm shift at the level of what these treatments are and how could they be delivered. Not, and then also thinking about the structures of our system, right? What clinic has what behavioral health clinic in this nation will have a therapy room free for the entire day for one client? That's almost impossible. Who's going to cover for that service? Who's going to pay for that? So I think there's this sort of this paradigm shift of the mental health system, as well as structures that need to come in. And then there's other things, stigmas, and a whole other sort of ball game that we have to think about for it. But those are some of the barriers that we're beginning to think about, and learn from this early intervention, early adopter study of what they think, and they have had to shift the way that they do their own work because of what's emerging from these new therapies.
Yeah, I think the main thing I would expand on there is just cost. Whether it be like the cost to run this intervention is like very resource intensive, right? In the best model, we have two therapists working as a team throughout all of the sessions together. So then you're paying two clinicians' time. Like Leo already mentioned, the dosing session, you need a room for 8 hours. We think a lot about safety net settings like federally qualified health centers, and it is difficult to find a room for a half hour, let alone 8 hours in those settings, right? So the intervention itself is very costly to deliver, but it's also very costly for participants. My big concern is that this is going to be a treatment that is only going to be accessible to Silicon Valley folks, right? And that's not okay. Like we simultaneously need to be focusing on advocacy to ensure that insurances are covering this treatment at an adequate reimbursement level so that providers are willing to offer the treatment that is quite resource intensive. So cost both for the participants, but also for clinics that are trying to implement this to figure out how do I get all of these additional resources and staffing components.
It strikes me that 8 hours and then I suppose some integration sessions, like the length of time and the therapist and personnel investment is really just shifting, just sort of shifting deck chairs around, right? Well, I guess maybe deck chairs is not a good metaphor, but you're sort of taking the same pieces, right, in terms of staff time, in terms of room time, and just putting it in a big chunk versus a lot of standardized interventions are 8 weeks, 12 weeks, right? It's the same amount of temporal investment. It's just, as you're saying, a really different model. You're saying, let's do this all at once with, a bunch of people in one room versus, one-on-one therapy that is sort of stretched out over time. What am I missing with that metaphor, though? How does that sort of not hold up, or what do you, is that an apt comparison?
Well, one thing I think you're missing, Kevin, I think it's a really important comparison that you're trying to do. But one thing that you're missing is also the burden on the therapist. This is, you can do one of this a day, and people are thinking of group interventions, but it's still one a day versus, let's say you're doing CBT, you might do 4 or 5 sessions of CBT a day with different clients. So that's also a component of the burden that this takes on as well. And then the question of how to pair it, how to integrate it to the existing services that are right. For example, in Oregon, a facilitator that might be a social worker and has a licensed social worker cannot pair these services. This license, you cannot have licenses in the same place. You actually have to do the psilocybin in a facility somewhere else, have that service combined, and then come into your services. So they're not integrated. And that's sort of the questions that we have. How do we bring this integration together if that's a way of implementing this at scale rather than in different places? So there's elements like that that take place. The other piece is that these are powerful substances. So you also have to have medical personnel available for issues of safety that may come up, so some side effects that might have happened. So that's also another component that some behavioral health organizations may not have a medical personnel on every time you do a dosing session as well.
So you really need to have specialized facilities or at least extra structures in place versus that. I have one question for each of you, since it sounds like you have training in this. How hard is it as a therapist to sit in a room and mostly be quiet and focused for 8 hours? That sounds really challenging to me. Maybe that's just, I have my own personal challenges with impulse control and attention, but I even just wonder for an average person, I just experientially, what's that like?
Yeah, I can speak to this as I facilitated a session, and it is pretty challenging, especially the silence component, because really, like as a therapist, my intuition is to check in, right? Try and understand what their experience is like, how are they feeling, and like really you want it to be non-directive. You want them to be in their own process. And so unless they are verbally talking to you and wanting to process something, you're trying to kind of let them be in their own internal world. And that's challenging. So for example, in one of the sessions I facilitated, for the first solid 2-3 hours, the participant was just in their own process, and it was silence in the room. I checked in with them maybe every 45 minutes or so. And then after maybe the 3-hour mark was when they really wanted to start talking and start processing. But for those first few hours, they were just kind of in their own process. And that was difficult for me because you can't read, you're really just sitting there in silence by yourself because you want to still be attuned to them. So yeah, it is challenging. And by the end of the 8 hours, I was exhausted, right?
I
I was
bet.
ready to take a nap. And so I think that that is a component that Leo pointed out too, is that not only can you only see one client each day, but it's also quite resource intensive for the therapist too.
Fully draining. Yeah, it sounds like finally there's a role for somebody classically trained as a Freudian and evidence-based interventions, right? That sitting in silence, just interpreting what's going on. Man, definitely
Mhm.
not the kind of CBT, not the training I got when I got trained in CBT, you know?
That's right. Absolutely. This is not manualized, at least the dosing session.
I suspect I suspect that the substance that they're using also has a large role in this. I've talked with again, I know a number of underground therapists, and they talk about MDMA just being actually a really wonderful experience for them. Super connecting as they're kind of getting the glow of the same feelings that their client is having. But I can imagine, especially somebody who's dealing with serious trauma, depression issues, using psilocybin, that might be a much harder experience. And then I know we haven't talked about this much, but I know it's becoming more prevalent. Ibogaine, that's the correct word, which is supposed to have like a day and a half long experience, something like that, 2 days, which I imagine there'd be a lot of handoffs between therapists for an experience like that. But yeah, I imagine that a lot of that is very substance dependent. I'm gonna switch gears a little bit. I know that Danny, you're in Missouri, and so kind of to us, liberal West Coasters out here, Missouri seems like kind of a surprising place for people to be working on psychedelic assisted therapy. And I'm just kind of curious about whether there's specific contextual factors that act as determinants, really, both facilitators and barriers for implementation of PAT in Missouri.
Yeah, I think one of the biggest facilitators that we have here in Missouri is that there's really seems to be bipartisan support for moving psychedelic assisted therapy forward through state level legislation. And a lot of that is happening because of veterans, because we have veterans groups who have really advocated for this in the state. And we have lawmakers that really deeply care about our veteran population. And our veteran population in Missouri experiences higher rates of suicide than other states, higher rates of substance use disorder. And so it really is a population that does need specific care and attention and resources. And so really since I think 2021, there has been laws at the state level trying to get passed to get this treatment approved for veterans specifically. Those bills have not passed, unfortunately, but there is a whole new round of bills in the state legislature that just got introduced last month. One of them is actually looking at approving psilocybin more broadly for the general public, and that one was also introduced by a Republican legislature or policymaker. And so I do think that we have bipartisan support for the treatment here, and that has been a huge facilitator. And I'll pass it over to Leo so he can talk more about WashU and the kind of like infrastructure and historical work that WashU has done in this space too.
Yeah. So we're also in Missouri. We're not in St. Louis, but following on Danny's component, this has been an interesting one where in basically where we are in this country, this is one thing that we're seeing bipartisan support, and that seems like an oxymoron in this world that we're living in, to put it lightly. But I think it speaks to something bigger here. First of all, the huge needs and increasing unmet need of mental health care for veterans and other vulnerable populations, and the failures of our system to really address and help reduce those needs and things like that. So I think there's sort of this wave that's happening where people are looking for other things to address the suffering that's happening. So I think that has created some questions around: is there something else here? Is there other promising treatments? How can we bring this to veterans? Population, and Missouri is not unique in this. There's other states that have been thinking of using the opioid lawsuits and settlements and use that funds for psychedelic assisted therapy. Ibogaine in particular is an example for substance use disorders. I mean, so I think there's also like a national movement happening around: can we try something new? Can we figure out some other type of treatment paradigm to help with this longstanding effects? So Washington University has done some of the work. More of the thing that has happened at WashU is more in the neuroscience type of thing. So not on the implementation side, but more understanding how these medicines work at a neurological level and understanding what's happening in the brain. And with new technologies of brain imaging, we are able to advance the science in a different way. So there's also this other world that we haven't talked about, that's not part of this implementation, but it's sort of like how these compounds and medicine can be used to understand the workings of our brains and seeing it in real time. So there's a lot of excitement of what can these drugs can help us understand how the brain works, and hopefully help us target very specific aspects of it. So WashU has done some of those trials more on the neuroscience type of things as a way of understanding. And then we are now doing some industry trials for the efficacy of it. But there's a real, I think that this speaks to a larger context of the need for new treatments in our behavioral healthcare system, and see if we can do something different to address these needs. And I think that journeying for better care, I think, cuts across political lines. Everyone's touched by mental health problems. So I think that there's that element of this goes beyond Republican, Democrats. It's all how do we address the suffering that's happening in our nation?
Yeah, I think as I was mentioning earlier, sort of the stigma of psychedelic drugs comes from a history of psychedelic drugs being more associated with sort of progressive political movements and these sorts of things. But I think the quote that may or may not be accurate attributed to Michael Jordan that, Republicans buy shoes too. Well, Republicans suffer too, suffer from emotional issues as well, and can benefit from these issues, benefit from these compounds as well. Super fascinating to hear. And then I think your point about veterans and the veterans groups just cannot be overstated. It's been such a powerful force from what I've read to have them lobbying for these compounds to treat their trauma. And they always have a lot more sway with, Republican policymakers. Really curious about where you see this field kind of headed over the next 10 years as we have this bipartisan support. Again, Missouri is such a fascinating state for this. But as you mentioned, Leo, the extreme difficulty that we have in bipartisanship right now, going along lines with that. So where is this going, and what role does implementation science have in this field?
So I'll start with that. I think one area we can look at is actually how the Veteran Administration is thinking about this. There was a recent special issue in the in the Journal of American Psychiatry. Did I say that right? American Journal of Psychiatry. And there's a great paper there that talks about sort of how the Veteran Administration is thinking about testing this in efficacy and beginning to plan for scale up. So they're really thinking broadly about what are the next generations of studies, effectiveness trial, setting up data systems, safety profiles, workforce development, and combining that with the existing implementation science that happens in the VA. So I think that could be one model of where this is going in a healthcare system, in an integrated or universal healthcare system like the VA, and think about all the different moving elements that can come into that. So that's one sort of place that I think this is heading to. The other ones have to do with FDA approval, what happens after FDA approval and how that gets scaled at large in different places. And there's where we need more moving from efficacy to effectiveness and implementation and begin to study what those are. And then lastly, I think we're going to learn lessons from Oregon and Colorado about how they have implemented. Oregon is 2 years ahead. They've already they're collecting data. They are beginning to think about, what are the challenges of the statute that they have, what are the challenges and the cost prohibitions that they have, how to address that. So I think we could learn also from those states and see how what we can learn and implement them in other. But we're in a weird world because we have sort of the system, right? We have states running this program, federal government not approving, VA moving forward. So this is sort of, I want to say, like a Wild West in a sense of like where this may be going, and it could turn into different directions. I think our job as implementation science is to provide the evidence and to hopefully provide guidance around how, if you implement in any of this sort of service systems or approaches or frameworks, what are some of the implementation science questions that we can address and help with it. The other component that we haven't talked about is the religious exemptions. There's also a whole other world of how to approve these medicines through religious rites. And there are already churches out there. The Native American church is one that had those religious exceptions. There's other ones that have come up as well. So there's also other policy components here that could play our way. But to me, I think I would love to see NIH, NSF, and other funders really thinking through about what the next generations of studies might be and begin to fund sort of large effectiveness implementation trials that could help address some of the existing questions that we have.
Yeah, I agree with all of that. It is a really interesting time because we also have some potential champions who just came into the administration for psychedelics. For example, Elon Musk, RFK has indicated that he's supportive of psychedelics. And so in that sense, there could be more champions at the federal level for this treatment as well. I think something that's really important to me is that we have to keep thinking about insurance coverage to ensure that this treatment is accessible, especially to those who need it most, right? And so for me, it's how do we get Medicaid to pay for this? And not just like, how do we get Medicaid to not pay for a watered down version of it too? How do we get them to pay for the version where there's 2 therapists in the room, where we do an adequate number of preparation and integration, where we see psychotherapy as a vital component of this treatment? So getting Medicaid and Medicare to pay for it at reasonable reimbursement rates so that providers will actually offer the treatment is huge too. And then we've already touched on the need for safety net clinics to have the infrastructure for this too. So really beginning to identify champions in these settings and getting the buy-in from those folks, I think is going to be vital. I think those are some of the next steps that I'm seeing and how implementation science can be really useful because we do this, right? This is our bread and butter, is thinking about infrastructure, thinking about policy. How do we get those barriers and facilitators and then develop implementation strategies, multi-component, multi-level implementation strategies to address those things at the policy level around insurance, at the organizational level around leadership, at the therapist level around training, right? We got this. This is what our field is meant to do. And so I'm super excited to think about all the ways that implementation science can contribute here with all the tools that we already have.
Yeah, it strikes me that, thinking about reimbursement and making sure they pay for the efficacious version of the treatment, I've had this recurring thought all along, like, what would the United Healthcare version of this treatment be? What's the race to the bottom? Is it, You have one person sort of sitting in a folding chair with zero training, getting paid $7 an hour to sit through people during their trip, And I don't say that to denigrate people with minimum wage, just like, it sounds like what you're doing and what it sounds really important and a really important role for implementation science is to sort of provide this evidence base for all the different ways that you could do this, in a way that would be efficacious. Here, you could provide models for here's what's optimal. And that strikes me as especially important in the context of that this is already out there, right? It's not like people are out there doing underground exposure therapy or, there's not like, hideaway, cognitive behavioral therapy clinics where you sort of like
Yeah.
have to have the password to get the really good, CBT, right? Um, uh, but there is for this, right? As we were talking, I searched for psychedelic assisted therapy in Seattle, and pages of Google results, come up. And the other part you're mentioning is that patients want this. So it's out there and people want it,
Mm,
right? It's actually, you're saying it's getting legalized because patients are advocating for themselves. So you're almost coming in behind them and saying, okay, hey, let's think this through and let's provide an evidence base for how to, implement this safely and at a high level of fidelity and in a way that really works. And hope, my hope, but I'm curious what your hopes are that would do. But it strikes me that I would be hopeful then that would at least provide a comparator so that when United comes along and says we want to do this in the minimum way, people could say, hey, look, we know there's a better way to do this. But yeah, what would you hope to see as an ultimate result from the work you're doing in terms of how this is implemented, how it becomes available in society?
Yeah, I agree with you, Kevin. I think one is the standardization and providing models of like this is the quality of care that you need to receive if you're taking this route and doing this therapy and these therapeutic approaches. Here's the safe components that you can do. One question that I think it's still open is who will benefit from this and who will don't. This is not for everyone. These are very
Hmm.
powerful medicines, and they might be group of people where this is not the right treatment for them. So being able to make that discerning clinical approach to this, that the other components, the regulatory components of the substances, that this is above board, that it's safe to take this medicine, that we know, people know, consumers know they're taking this doses of this molecule and it's not adulterated with other substances that might create serious issues. That there's safety around adverse events and are being addressed, so we don't repeat the errors of the past that we've done with opioid and other substances that have been moving forward. So I think those are some of the hopes for the future. And that this helps us think about, to me, one of the hopes for the future is that this helps us shift sort of the conversation of behavioral health, that it's not just take a pill and everything gets fixed, but there's larger components here. You're talking about your life, your traumas, you have a way to process it. You're touching upon other therapeutic elements here that are helpful, flexibility, spirituality. So the broadening how we understand in the Western models, we broadens the view of looking at mental health and well-being. That we have done. We have pathologized so much things. This could be a shift in that. But I'm cautiously optimistic that that's where we're going. But there's still quite a lot of things and pitfalls that could happen here with these medicines and approaches.
yeah, for me, it's that the treatment is accessible, meaning that folks can access it in a timely manner and that it's affordable. And the second key component to me, my hope, is that our workforce for this model is culturally sensitive, that they reflect the folks that they are serving, right? So it's not all just white women providing the treatment. We have folks of color also providing treatment and getting trained up in the model. And then finally, that workforce is adequately supported, that we have good models for supervision, for technical assistance, and that they're paid well, and that they themselves feel like psychologically supported so that they can do this treatment with fidelity and they can be fully present those whole 8 hours in the room, right? They need to also have their needs taken care of. So that's my high horse, is that the behavioral health workforce just needs to be paid better and treated better in general, because we have a lot of exploitation in this field. And so I would really like to ensure that this workforce gets the adequate support that they need to.
Such an interesting question, such an interesting comment, rather. Again, I think about the underground workforce right now, and these are all true believers, and they're sort of self-selected into this. And there's a lot of mutual support, and I think they get a lot of, personal rewards out of doing this work that I'm not sure if somebody who wasn't a true believer, I don't know what sort of experience they would have, as Kevin described, the person sitting in a folding chair for $7 an hour, maybe a very, very different experience. And these are things that I'm really glad that you all are thinking about. Okay, so now it's time for the real reason why we invited you on the show, which is to play our game where you get to rant about the implementation science field. It's called Don't Get Me Started. And you're going to have 1 minute. We'll go back and forth between Dani and Leo, and you can just begin each rant with "Don't even get me started about," and then rant about what you want to rant. If Kevin and I think that it's a good rant, we will make a ding sound, and that means you get 1 point. And in 1 minute, you need to get what? 5 points? 6 points?
It's really hard to say, Mike. We're scientists, and we're going to have to look at the data after we've collected it and
It'll be an
decide.
emergent. It's like this is more of a qualitative, emergent, grounded theory type of thing. So,
Oh, no, dude, we do that in quantitative too. We collect the data, we look and see if it tells us what we want it to, and then we decide what to say about it. And if you're not aware, the prize is that I will write a personalized out of office message for you for the next time you go on travel. And in case you haven't heard mine, I think they're particularly funny. Not everybody does. But here's one that I wrote for Danny Almiral after he was on the podcast. So he was traveling to Northwestern to give a talk, I think. And so I wrote, this is one of the examples. I'm out of town for a short trip to the beautiful town of Evanston, Illinois, to visit Northwestern University. It's called Northwestern because, well, I don't know. It's actually kind of right at about the median center line of the population of the United States. It's neither northern nor western, but somebody decided they'd apparently just pretend it's both because I guess that makes it more interesting. I'm guessing I won't be finding that out during my trip either, so don't expect enlightenment on that front. Just expect a delay in my replies to your email. So I'm happy to, again, customize it however you want. I can even try to be funny, unlike that last one. But okay, Mike, do you want to go ahead and kick them off and get them started?
yeah, let's go ahead. And all right, let's go.
All right, I can start us off. So I get really frustrated about implementation science, lack of attention towards structural factors impacting our mental health system. So, for example, earlier I touched on the exploitation of the mental health workforce. This is a huge issue. Our turnover rates in the mental health system are up to 30% every year. That means that our entire workforce turns over in 3 years, especially in community mental health. And so, for example, my colleague, Dr. Brianna Last, and I, we just finished up a qualitative study looking at the impact of unionization on our public mental health workforce, because we know that unions. Yes, unions can be a huge facilitator for improving work conditions. And yet we don't think about unionization as like, what if this is a potential implementation strategy to support our workforce, right?
Ding. That's 1 minute. That was awesome. I counted 5 dings, all from me. So I don't know if there's a bonus or a penalty for only one of us dinging, Mike.
I mean, your dinging was going so well. I didn't want to step on your ding.
Okay.
You need more dings, Mike.
All right. I think it's Leopoldo's turn next. Whenever you're ready, don't get you started.
All right. So don't get me started about implementation science and health equity. We do not, in implementation science, we have way too many frameworks and that nobody can test. And there's quite a lot of papers that have enormous impact in the field, but they tell us nothing about how to actually do implementation science on health equity. One of my pet peeves is that we don't need more theories. We actually need to start testing theories and frameworks. With a great colleague of ours, Dr. Nagy and Elio Segarra from Ponce Health Institute in Puerto Rico, we've written a paper of actually those of us that do health equity, how actually do it with implementation science and show practical approaches for actually how to bring equity into the work that we do, instead of aspirations or values and things that which are important, but we actually need how to actually do this. And that implementation science did not discover health equity. There's a whole
Ding.
field of health.
And that's ding, ding, ding. That's our whole minute. But Leo, you should finish your thought because you were
That
right in the
we
middle.
need to partner better with health equity researchers and implementation science. We need to come together and learn from each other.
That was great. That was fantastic. Wonderful rants. How did they do, Kevin?
I lost count, but I think they had at least 5 dings in a minute. So I feel like at a, seconds per ding rate, they did enough to both earn a custom out of office message. So next time you end up leaving the office or just decide to like stay home because it's a snow or a freezing rain day, I'm happy to send you a custom message. Just give me about a couple days heads up and I'll give you a couple of options to set your out of office message.
Awesome.
Very
I'm looking
nice.
forward to that.
Yeah.
That was great.
Before we wrap up, we'd love to hear your opinions about 1 or 2 articles that you feel are most essential to implementation science. And I'm expecting at least one of those will involve frameworks or theories based on that last rant. No, what are articles you think people really need to read?
So I loved, actually, when I saw that question, I actually thought this is the only question I prepared for. To do that. I would say one that I love, it's not implementation science, but it actually at the heart of implementation science. It's a paper from 2011 from Edison Trickett. And I love this title. It's called From Water Boiling in a Peruvian Town to Letting Them Die: Culture, Community Intervention, and the Metabolic Balance Between Patient and Zeal. And it's actually a commentary. What was this? This is a keynote address that Trickett did for the Society of Community Research and Action. And it's really talking about context. Like if you forget about understanding the context in which you put your interventions will fail. And this is a case example of 2 interventions that completely fail because the researchers forgot to talk about the cultural context in which the interventions that they were trying. So it's a beautiful piece on that component that sometimes we think about doing good, but we forget about sort of the context in which our interventions are being implemented. I think that's a great paper, entertaining and not theoretically based.
I love that. That sounds so interesting.
Okay, well, I'll give you a theory one then. So my article is going to be by Ramesh Raghavan, and it's the Policy Ecology Framework. And it's from 2008. And I really love this because, like I was saying earlier, I think we don't pay enough attention to structural level factors in implementation science. And I think that this article actually gives us a framework for how to do that, how to pay attention to the political level factors, the social level factors, right? Stigma, like we talked about earlier with psychedelics, organizational level factors, and then thinking about how all of those pieces come together and interact and inform each other. Because we know that it's not just about delivering the intervention to fidelity. It's about supporting that therapist. It's about making sure the agency has the resources to support the therapist to deliver the intervention, making sure reimbursement rates are high enough, right? Making sure that parents or individuals are demanding that treatment. So there's all of these various contextual factors. And I think that the Raghavan Policy Ecology Framework really gives us a tool to help think about and put all of those things in one place. So sorry, Leo, had to throw a theory in there.
No worries. And I have one more.
Yeah, please.
So this one, actually, this paper came to me. It was one of the first implementation science papers that I ever read as I was doing a KO application, thinking about implementation science, how I'm going to address this. And John Landsberg sends me this paper where I got it and I immediately read back, emailed him back and said, I think you sent me the wrong paper because this is about NASA and about behavioral health in NASA. And I'm doing stuff in health equity. And saying, no, read the paper. And this is a wonderful paper by Lawrence Palinkas called Models of Research Operational Collaboration for Behavioral Health in space. And it's actually how to integrate mental health and behavioral services in the NASA culture, and talking about the importance of cultural exchange that happens within it. It's a great model of how, if you introduce something new into our organizational culture, you have to pay attention to this cultural exchange between them, the dynamic elements of that. Beautifully written. Is my introduction to Lawrence Palinka's work, and we've become great collaborators. He's one of my mentors for that, but it's just a paper that really began to speak about that cultural exchange that happens when you try to bring an innovation into an organization such as NASA that has its own culture and things like that. So
great papers. Thank you for sharing those. I haven't heard of, I think, any of them, so I'm going to go check those out.
I think it's a first for the podcast. I think these are and the first time maybe somebody hasn't highlighted Brian Weiner's work. So that's it's also exciting. I was kind of getting tired of him.
And I'm pretty sure nobody implementation science reads what is this? This is in aviation, space, and environmental medicine.
Wow.
So out there.
Awesome.
Yeah.
Just to finish this off, do you have any shout outs you want to give anyone?
So I would give a shout out. So the two shout outs I would give actually is to Heidi Allen at Columbia University, who actually was the introducers to this field of psychedelic assisted therapy and opening the door for us to learn about it. Heidi is an incredible health policy researcher, and it's sort of fascinating to see her work. And then my other shout out is to the Center for Holistic Interdisciplinary Research in Psychedelics, our new center here at WashU, led by myself, Ginger Nichols, and Rebecca Lester. And it's a great investment that WashU is doing on this field, and it's really bringing sort of an interdisciplinary approach to psychedelic assisted therapy work.
Yeah, I have to second those shout outs. I mean, Dr. Heidi Allen and Dr. Ginger Nickel have just been fantastic collaborators, and really kind of Dr. Allen bringing us into this work to have the opportunity to get trained by MAPS was really an incredible experience. And then I have to give a shout out to Leo, who was my mentor during my postdoc at WashU. This work would be really challenging to do without strong mentorship. And Leo has been just an amazing mentor in this space and really helping push along the science, but also be a leader both within WashU and more broadly in this area. So I'm just really grateful to work with Leo in this space too.
Thank you, Dani. Stop it. Yeah.
And if folks wanted to get in touch with you, find you on social media or find you just on the internet, how should they go about looking for you?
I'm in sabbatical. Do not reach out to me. I am not going to respond you to anything. No, but the easiest way to reach out is to email me, and it'll take me a while to respond, but happy to respond. So
I do have a Blue Sky now, though, so you can find me at Dani Adams, DANI Adams.
Excellent.
All right, guys. Well, the mushrooms are just starting to kick in for me, so it's time for me to go. It was so wonderful having you on the show. Thank you so much. I learned so much. This is, as I said, this is one of my favorite topics, and I really enjoyed talking with you all. I look forward to seeing you at future conferences.
Likewise. Thank you so much for having us.
Thanks. That was real fun.
Thanks so much for listening. I hope the trip was beautiful and insightful. You can reach Kevin on Blue Sky at Kevin M. King. All of the comments and opinions expressed during today's show are our own. They are well-reasoned and insightful, and therefore are probably not endorsed by our grant funders or employers. Thanks for listening. On behalf of Kevin King, we'll catch you next time. Dani already talked about how great Elon and Robert
No!
Kennedy is,
Yeah.
so we're good.
Do not quote me saying that.